Hi, Father. Good evening.
Good evening.
May narinig ako from a Jew, Father, si Dennis Prager, yung sa PragerU. He commented about the fifth commandment. Thou shalt not kill, and he comments that in the original Hebrew it says thou shalt not murder, and he points out the big difference between kill and murder. Yeah, of course, murder is taking away something from someone.
Yeah.
That is life, and he pointed out yung difference between kill and murder. So what's your comment on that, Father?
Yeah, if I'm not mistaken, no, that of murder, that of murder is intentional homicide. No, it's like against a person, and it's specific. And whereas killing, on the other hand, is more generic. That's as far as I know. I could be wrong, huh?
Thank you, thank you.
Father, when my mom passed away 7 years ago, and before she actually got sick, we were already talking about what she wants to happen, no, when she gets sick.
Okay.
So her instruction was do not resuscitate. So I think, if I remember it right, because this was 7 years ago, we sort of signed that waiver already, I think in St. Luke's.
Okay.
So when my mom was becoming critical, they took out that paper, and the doctors and the doctor or the nurse at the time asked us to sign as well. It's sort of like a confirmation that we're okay with it. Kaming father magkakapatid, we're okay with it because my mom, would always tell us that even before she was well.
Okay.
Initially it was okay with my dad, but I think at that point, because him being the husband, I remember him saying, kung pipirma ako dyan, para bang give up ko na siya. And di ba, Father, parang from a point of view of a husband, at the end of the day, he's the husband. He can also decide, right? So if the husband does not sign on that waiver, because of course he sort of like wanted that person or the wife to still try to live, is that, Father, parang wouldn't there be a conflict between what the patient wants and what the husband wants, wherein the husband also wants to still have that life, diba, for the wife? So what can be your comment on that?
Dr. Liza will talk about DNR, in fact.
Death and dying is like a daily thing for us, and we talk to terminally ill patients and their family as a matter of course, on a day-to-day basis. So in the first place, it's very good for the doctor to have established rapport, not only with the patient, but also with the family. And usually, for example, in the case of your mom, obviously, hopefully, when your mom would seek consult with a doctor, your dad or your siblings would be accompanying your mom. So having said that there's a good rapport between the doctor, the patient, and the family, then every step of the way, the doctor would also explain the nature of the illness, the way it's going to develop through time. Now we call that the natural history of the disease, and then the prognosis. So having said that, so it's a gradual sharing of information with the patient and the family. And then at the same time, the doctor takes it upon herself to elicit the preferences, values, and wishes of the patient, and it's something very, very personal. So in a sense, you might say there's really no right and wrong about the whole thing, about the end-of-life preferences of the patient. So having said that, if your mom had left that advance directive, we call it, that she didn't want aggressive heroic measures at the end of life, meaning she doesn't want an endotracheal tube, a tube to be inserted in her mouth, all the way to the throat, to the airways, to the lungs, and then to be attached to a mechanical ventilator. I suppose that is something that she has thought about, prayed about, and it's really something that she wouldn't want, especially, for example, if in the end, it's not really going to prolong her life with good quality of life. So the thing there is, we would like the patient to to exercise her autonomy in decision making, meaning she herself weighs the benefits and the risks of every intervention that the doctors are recommending, and weigh that against the prognosis. No, so therefore, if your mom was competent when she made that decision, that she's in the full possession of her mental faculties, she's not depressed, she has no neurologic condition that would affect her thinking process, then in reality, we as doctors follow the patients more than the family members. Our first allegiance is with our patients because in the end, we have been making them partners in the decision making every step of the way. So that's why with every consultation, we explain everything as clearly as possible to the patient and their family. So the first there is we obey the patient more than what the family members want. And then the second there is actually that in principle, with every consultation, the surrogate decision maker accompanies the patient. And therefore, that surrogate decision maker would have heard the discussion between the doctor and the patient. And she would have heard, or he would have heard, why the patient chose that course of action, that she didn't want aggressive measures at the end of life. No? So naiintindihan niya kung bakit pinipili ng pasyente na no more intubation, no more heroic measures at the end of life. Now, of course, when I talk to family members about this, we always say that ang first namin is naghaharap-harap po pa tayo dito para pag-usapan natin yung pasyente. Tapos po, ang gauge natin is we're going to be considering the patient's best interest. So while we're here discussing about end-of-life care, let us personally try to set aside our own preferences, wishes, for ourselves and for our loved ones, and I invite everybody to act in a similar manner. So parang kumbaga, we will try our best to look at it not from our point of view, but from the point of view of somebody who's sick and dying. Because many times, especially if they're terminally ill, they have been through a lot already. So you might say death for them is not something unwelcome. For many of them, they look forward to it. Not only as an end to suffering, but especially if you have accompanied them with spiritual care, they look forward to going to heaven already. And many of my patients tell me that they want to go to heaven already. You know? So it's not something that we should grieve about, even if of course we love our parents, for example, but with that whole idea that we are actually making them happy, giving in to their wishes, because it's a wish that they have thought about and prayed about very well. I hope that answers your question. So therefore, the one who signs the advance directives, the do not resuscitate, that allow natural death, is actually the patient as much as possible. And we bring this up not at the end of life, but upon the diagnosis of a serious illness that could be potentially life-threatening.
Yeah, thank you, Dr. Liza. But could you tell us, for those who are not yet that familiar with the form, no? What is that form that we are talking about? Because people have consulted me as priest. Now, Father, the DNR is there and there's some guilt or some, I don't know, reservations. Maybe if you have there, you know, or you could show us the form and what considerations, you know, who has the right to consent aside from the patient? Is it the spouse? Now, other ethical guidelines in broad strokes about this.
Okay, so Father, each institution has their advance directive forms. It's something that has passed the ethics committee and even the medical legal committee. No, so, and of course, all the clinicians have seen the advance directive forms, and they could give their inputs about how it's phrased and how it's easily understood by patients and families. So basically, at least in the institution where I work, the advance directive forms consist of two forms. One, before the patient actually dies, meaning there's a risk of dying. So in such cases, a code would have been called, meaning a code would be like all the doctors running all over the place to reach the patient's room and give heroic aggressive measures. So that's when, so the blood pressure is going down, the oxygen is going down, the patient is at risk of dying. So therefore there's a code is called so that the doctors can do something to prevent the person from dying. So the first form addresses that do you want for us to call a code in the first place? Okay. Because if, for example, you have advanced cancer and you're terminally ill and dying, to be honest, a code will not be very helpful, really. You meaning it might give you a little bit of time, prolong your life a bit, but that the trade-off for that would be the intubation, the mechanical ventilation, and the ICU stay, which means we will be taking you away from your family, and your family members will only be able to visit you at a certain hour of the day. So in our institution, the form consists of 4 parameters. First is, in the event of a near arrest, would you want us to insert a breathing tube in your mouth and attach it to a mechanical ventilator? Okay, so that's all about airway and breathing. Second would be, just in case your heart has some abnormal beats to the point that you might suffer from a heart attack, do you want us to do defibrillation? So it's like what you shock the patient, what you see on TV. So that will normalize the beating of the heart. And of course, that shocking is really like an electric bolt to your body to normalize the rhythm of the heart. So therefore, it's not really risk-free, and it's not really comfortable, you might say. And then the third would be, if your blood pressure is going down, so that's about the cardiovascular, right? So ABCs kasi of resuscitation, airway, breathing, and circulation. So the third parameter would be, would you want us to give you drugs that will bring up your blood pressure? Because when you're dying, you might say all the organ systems are going to shut down, including the cardiovascular system. So your blood pressure is going to go down. So do you want us to give a drug that will bring up that blood pressure? And then the fourth parameter would be, do you want to be referred for palliative care, and you want comfort measures at the end of life? Okay, so basically that's what our advance directives is contain, and more than a do not resuscitate, which is something negative. Kasi it was mentioned earlier in the question that, are we giving up on the patient? Many of our patients would actually say that, na, Doc, lalaban ako. And then the family members would also second that, no, Doc, lalaban si Mami, Doc, lalaban si Daddy. And the way I explain it to family members is, ang sakit po, hindi po gera. No, it's not a labanan. Because if you look at it that way, there are certain illnesses that no matter what the patient does, and no matter how good the team of doctors attending to him or her is concerned, no matter how good they are, they're the best doctors around, they could still be terminally ill and they would still die, right? So because that's a natural history of that particular illness, like an advanced cancer, for example. So pag sinasabi mong, Doc, lalaban ako, you are actually putting a lot of weight on yourself and on the sick person if you're the relatives, di ba? Para bang kaya siya mamamatay kasi nag-give up na siya. Kasi hindi siya lumaban. Hindi naman gano'n, di ba? Kaya siya namamatay kasi nakakamatay yung sakit niya. At hindi dahil sa nag-give up na siya. No? So it's not about willpower. No? Getting well and overcoming a serious illness is not willpower. We all know that. I mean, the different organ systems are beginning to shut down already and succumb to the disease. No? So it's not like you're giving up on yourself, on your family. Kasi para hindi din mabigat para sa pasyente at sa pamilya.
Okay.
Okay, so basically that's what it is, Father. So for the relatives naman, they should not feel like they're giving up on the sick person, on the dying person, just because they signed the advance directives. Because the way we explain the advance directives is, first, that will be allowing the natural history of the illness to proceed in a natural way. Second, just because we're not going to give aggressive heroic measures, we're going to maximize comfort measures. We'll still be giving her oxygen, but in a non-invasive manner. So hindi tutubuhan, but through a face mask, a non-rebreather mask, things like that, high flow nasal cannula. So walang nakakabit sa loob, meron sa labas lang. Non-invasive ventilation, we call it. So may oxygen pa rin, meron pa ring swero, meron pa ring pagkain. So only the heroic aggressive measures will not be given if it's no longer beneficial to the patient. So maximum comfort measures.
Okay. I have a follow-up question kasi you mentioned something about ventilators, no? And now that we are in COVID, this thing is really a big question mark in relation to whether do we go for it or not, etc., etc. So my question is this now. So when you talk about ventilators, are we talking about a measure that's immediately extraordinary? Kasi may case rin regarding a question of euthanasia, no? Is it euthanasia to remove the ventilator? No. Okay, I'll mention the case. No, let's invent names here. No? Johnny, he had a stroke. No, and he was in coma for 3 weeks. So after a series of CT scans and other tests, the doctors informed the wife, her name is Paula, that her husband was almost brain dead. So the chances are he will remain a vegetable even if he wakes up. So the doctor asked her for advance directives, no? And Paula found it quite difficult to sign the DNR form. Moreover, she was encouraged to move her husband to a room, which meant they would remove him from the ventilator. So lumapit si Paula sa pare, and of course the priest will have to give advice. And I suppose the people attending this class will also be asked later on or be in a situation of a relative. How do we assess this regarding euthanasia and ventilators?
Yes, Father. That's something that we face every day, with patients and relatives. So actually, Father, the answer to your question is it's always a case-to-case assessment by a multidisciplinary team. So meaning it's not just the attending physician, but everybody who has a major role to play in the care of the patient will have to put their heads together and prognosticate. So they should be able to tell what are the chances of survival of a patient, not only to prolong the life, but also with good quality of life. So dalawa palaging bagay ang tinitingnan namin. Hindi lang yung buhay, pero buhay with good quality of life. Because you mentioned about the probability of the patient turning out to be a vegetable later on. No? So having said that, so if, for example, in the case that you cited, obviously the prognosis is poor, Father. One, I want to establish that you don't need to be brain dead for ventilator withdrawal to be done ethically. You don't need the criteria of a brain death for the ventilator to be withdrawn ethically. Now, because there are very few cases of brain deaths. Now, meaning our cancer patients don't die of brain death. Our cancer patients die of infection, usually sepsis, and multi-organ failure, but not brain death. So if your criteria for ventilator withdrawal will only be brain dead, then that's practically will not allow ventilator withdrawal to any of our cancer patients, for example. So having said that you don't need to be brain dead for ventilator withdrawal to be done, as I said, the multidisciplinary team decide about the prognosis of the patient. If the multidisciplinary team agree that the prognosis is poor, meaning the chances of dying is very high, like 95% chance of dying. And the ventilate, so in any intervention, Father, you allow for a certain time for the treatment to work. So for example, if you're giving antibiotics, we give ourselves 72 hours. How is the antibiotic working? Okay, wala pa, change antibiotics, another 72 hours, and things like that. So there is a prudential waiting period to check if the interventions are working. So we don't easily give up on our patients as well. So only if the team has done what they have to do to save a patient's life, and they think that despite the best efforts of the doctors and all the interventions that have been done, it is more burdensome in terms of because they're usually difficult to insert, no? Yung lagi ko sinasabi na lahat ng butas sa katawan may nakapasok. Ang wala lang nakapasok na tubes will be the eyes and the ears, kasi hindi pwede pasukan. So there's something in your nose, there's something in your mouth, there are 2 tubes in your lungs, there's a tube in your stomach, there's a tube in your urinary tract, you have IV lines in your 2 hands, sometimes also in the 2 legs, something like that. So tadtad na ng IV insertions and IV extraction yung pasyente. So with that, therefore, the ventilator being an extraordinary means of life support will be dependent on the case. So you talked about COVID father.
Okay.
If the patient was previously well and intubated, that is an ordinary means of life support, because critical COVID, the oxygenation of the patients go down to the point that the patient will die. So if the patient has a fair enough chance of survival, we'll definitely intubate our patients.
Okay.
And give all the things that are needed to support the ventilator. So it's not just ventilator tapos wala kang gagawin. Eh, hindi gagaling yung pasyente mo kung wala kang gagawin. So then only if, so in the same patient, father, in the same patient, it's probable that the same means could be ordinary at the beginning of the illness. And as the days go by, the weeks go by, the months go by, then it already becomes an extraordinary means of life support. That's when we will propose ventilator withdrawal.
Okay, okay.
And ventilator withdrawal in this case will not be unethical, because the doctors have allowed a sufficient amount of time to observe if the treatment is working. And after the prudential observation on the part of the multidisciplinary team, the patient is not getting any better. And in fact, it's obvious that he's getting worse. And everything we're doing is just prolonging the dying of the patient. Then we allow natural death. That's why we propose ventilator withdrawal.
Okay. That clarified many things, Dr. Liza. I don't want to monopolize the questions. So we hope that we could have you still. Is it okay you stay? And for the open forum, we'll have our second guest in the meantime to talk about issues about initial stages of life. Huh? Thank you, Dr. Liza.
Sure.